Hello everyone, this is NainaMD, Fusion of Science and Beauty. Welcome to my show right here in Beverly Hills. And today I've got a fabulous guest. As you know, my passion is in anti-aging and regenerative medicine. And sometimes we have certain conditions, such as obstructive sleep apnea, yet the treatment might just be a little bit different than what you guys are usually used to hearing about. And this guest of mine is amazing. His name is Dr. John Wallace. He's been a dentist for almost 25 years. Welcome, John.
Thank you
How
so
are
much.
you?
Oh, just fine.
Today, I really want you to talk about the audience about obstructive sleep apnea. This is affecting younger people, older people, and we're finding that actually younger people who we, at unexpected ages
Sure.
are encountering sleep apnea.
Yeah, even small children. Yeah.
That's what I want you to go. Why is that? Please tell the audience, first of all, what is obstructive sleep apnea, and what are some of the symptoms, and then why is this happening? Did we just not know about it, or is it really seriously starting to increase?
Yeah, it is increasing. Obstructive sleep apnea is a serious medical condition wherein when the individual is sleeping, especially in a deep delta wave sleep, which is really what we want, of course, there's a profound relaxation, as we know, and as it turns out, that sort of backfires, especially in the patient who is predisposed for sleep apnea, and we'll get to that. But essentially, when we're lying, especially on our backs, there is a collapse of the oropharynx. Of course, we have the nasopharynx where the air comes in through the nose, but also air can pass through the mouth, or both. But there's a vulnerable place. It's about 10 centimeters down from the tip of the lips, where the oropharynx collapses onto itself. In a sense, it's sort of your tissues collapsing onto yourself. And ultimately, the word apnea, by the way, comes from the Greek, and it means very simply no breath, no air whatsoever, no breathing. And so the typical pattern then would be the individual that snores, which is a mitigation or a lessening of the airway, and then ultimately the complete collapse wherein there is no breathing at all. What happens then, of course, is that the brain will only tolerate that for so long. There comes a point where the brain calls time out and literally wakes you up, either to complete consciousness or almost to consciousness. And if you watch videotape of people that are suffering from moderate to severe sleep apnea, first of all, there's a battle going on for air. We know that the brain prioritizes body functions, but the brain will never relinquish the number one priority, which is oxygen flow into the body.
So when it doesn't get its oxygen, it's
Yeah, and so, I'm sure you've seen videotape of sleep studies, and there's a violent battle for air, and then ultimately, when the brain just cannot tolerate another second, really, of no breathing, then there's a gasping for air, almost a violent surge. And often patients will explain it as they feel like they're drowning, or they will dream. They'll be in a dreamlike state wherein they feel like someone's either choking them or drowning.
And oftentimes, and one of the key things is that they'll come in really tired, or just sort of like a brain fog, or just they're just not, tired all the time.
And
it's not really an ADD issue. You kind of rule it out. And then when I kind of used to get in my history, so my typical presentation was, you would say, okay, they're snoring, they're tired. You send them usually for the diagnosis, which is obviously the sleep study, right? You go to a sleep lab and you get the diagnoses. But then a lot of times these patients were referred often to the pulmonologist onto a whole different, like a CPAP and so forth. But this is what I want to really focus on, is that a lot of the dentist community is starting to look at this and really say that, look, through manipulation, through certain things that they could do, and this is what you're here to talk about, that you might be able to help at least enhance that opening of that nasopharynx or pharynx, right?
That is exactly right. There are two ways to get
Tell
oxygen.
me how is that? Yes,
that's right.
How is it as a dentist that you can? Because look, the other option is that CPAP machine. This has been my biggest issue. Majority of my patients will not be compliant.
Yeah, that's right.
There's no compliancy.
Yeah, even those that...
Or they'll just tear it off.
Yes, and a lot of times, especially with my big burly guys, they want to wear CPAP. They know that it is... And by the way, CPAP is an ingenious invention.
It is,
and
but
it literally
nobody
forces
can
air, but no one can wear the darn thing, and that's unfortunate because they'll go to bed...
And no matter what we try with the cannulas or the masks or this or that, We try so hard,
Yeah.
but the compliancy and just at night, they're just...
It's very poor.
It's poor.
There's a recent study that demonstrates that only about 15 to 20% of adults with obstructive sleep apnea can wear CPAP. So
Wow.
now
I believe
contrasting with the CPAP, and for those that don't know what CPAP means, it stands for continuous positive air pressure.
By the way, how many people are now affected?
Well, that's a great question, and the fact is we don't really know because first of all, it is underreported, it is underdiagnosed. But there are reports that would suggest that there might be as many as 70 or 80 million adults with at least mild sleep apnea. Patients that have severe sleep apnea, I can walk down the boardwalk or the mall and I can point out to you exactly who they are, both men and women. There's a very characteristic sort of ashen gray complexion. You've got the venous pooling, the dark rings under the eyes. Our classic snorer is a heavy-set man with a big neck and dark rings under his eyes.
What about for women?
You know, one of my most severe patients.
What would they look like? Yeah, yeah.
Yes, similar, you know, certainly obesity. Well, first of all, gender is the #1 predisposing factor. Men are affected by it more than women.
Okay.
But on the other hand, the adult obstructive sleep apnea in women is underdiagnosed and underreported in women even more so than men because for some odd reason, it's an embarrassment for a woman to confess. I'll say, hey, Mary, and I can tell, doc, just looking in her eyes and in her face. Hey, how do you sleep at night? Fine. Do you snore? No. And hubby will say, are you kidding me right now? She snores like a freight train, you know. Whereas when I ask a man, especially the big burly guy, you can picture him, right? I'll say, hey, Tom, do you snore? Yeah, I snore.
A lot of times,
it's a badge of honor.
The reason I picture them is because a lot of those same men will have the metabolic syndrome.
Yes, and of course,
they'll have the insulin, either whether it's a pre-diabetic or diabetes, blood pressure, and then it goes on to heart.
Yeah, that's right, and around it goes. One of the more unfortunate and really almost cruel aspects of obstructive sleep apnea is, and we were talking earlier about the oxygen deprivation, but it's also sleep deprivation because, you know, we talk about how the brain must wake you up out of that deep sleep. And so if that occurs over and over and over again, it's the equivalent of lying down in the afternoon because you're pooped and you want to take a nap, and your girlfriend wakes you up every 2 or 3 minutes. Hey, doc, you know, and at some point the frustration would grow, of course, but at the end of the, let's say, hour that you've spent on that couch, you're not rested because it's being interrupted, Now, when I ask patients, hey, do you wake up over and over again gasping for air in the middle of the night? They'll say, no. And once again, spouse will say, yeah, you do. It's weird because you'll be real quiet, real still, because the apneic patient is as peaceful as can be. They're not breathing, but they're at peace.
Wow.
You know, and then the violent gasp for air. Now, if the bed partner is a deep sleeper, even he or she may not be able to pick up on it. But to answer your question, in the tens of millions. Now, there is a rise, to answer your question from earlier, as we see obesity rates increase, we're going to see an increase in sleep apnea as well, because the heavier one is, the bigger the neck, the more flesh, and the more collapsibility of that flesh. So and then as that obese person,
why are we? Okay, another thing. Why are we seeing more of an increase of people?
Well, I have two theories, and
what's your take on it?
First of all, you know, I was born in 1965, and I'm part of a generation of certainly, especially amongst Caucasians in the United States, where from an orthodontic standpoint, if you're an ugly kid and you got crooked teeth, well, the orthodontist would remove 4 bicuspids, throw you in headgear, and drive everything back. It was a form of cheating in a sense. The teeth there's not enough room. Oh, let's remove body parts and drive everything back. The problem, doc, is we know now that the volume of one's oral cavity, which is predicated on the upper jaw, the lower jaw, the tongue, the cheeks, think of it as like a garage, so to speak. It's limited. It is finite, but as it turns out, the volume of the oral cavity is directly related to the volume of the oropharynx. So guess what? I truly believe, and I've got colleagues that have written papers on this, that there is a generational almost syndrome of small oral cavities. You know, Dr. Ahn and I, we see it all the time. It's an orthodontic oops that we've rectified to a great extent because we just don't pull body parts out anymore in the form of bicuspids. But interestingly, you know, the issue of difficult breathing, or I should say difficulty breathing and sleep apnea starts with children, especially in those who have difficulty breathing through their noses. Noses are for breathing and mouths are for eating. So very quickly, I will demonstrate for you that when a child breathes through their mouth, when they become mouth breathers, and you've seen it, little toddlers.
I have. Yes, I have.
There are facial muscles, the buccinators in particular, that are firing which should not be firing. Normal sleep is quiet through the nose, very neutral. We call this parafunction, and believe it or not, there are two things that happen. One is the tongue must drop down during mouth breathing in the child. Tongue drops down, therefore does not support the palate. And then muscles fire over and over again to squeeze in an unsupported maxilla or upper jaw. And so narrow upper jaw, lower jaw must accommodate, narrow lower jaw. And so as it becomes more and more narrow, as the palate goes up into the nose, it's even harder for them to breathe. So parafunction and mouth breathing can lead to, let's put it this way, childhood sleep apnea then becomes adult sleep apnea, unless that's rectified.
Wow. So in other words, you can pick this up early and start maybe modifying the food. It's so important to do. So that just by watching how the child may be breathing, you could affect those muscles and start to deal with this.
Oh, we're seeing amazing results already. And I had a patient, if you don't mind, just a few weeks ago. She has been sleeping in her 7-year-old's bed. She's a single mother. And she cries herself to sleep every night because she said, Dr. Wallace, she goes, I think Freddie is dying. It sounds like he's dying. Well, he has severe pediatric sleep apnea. I said, well, Mrs. So-and-so, I go, he's not dying, but he's really struggling to breathe, and that's why he has to breathe through his mouth. I went through the whole thing with her. Right. So just with Dr. Ron, in fact, is on this case, and we're expanding the jaw. We're opening his little mouth and his airway. He's able to breathe through his nose now.
Amazing.
And in time, because there is nothing else in that healthy little body that would indicate.
And you know what? And oxygen is the basis of everything.
It's the currency of life.
It's the currency of life. So listen, what is the website? Because we're getting into commercial break, but we're going to be right back. What's your website?
The Center SW, which is Sleep and Wellness.
Okay.
TheCenterSW.com.
That's right. And so it's Center SW?
Yes, TheCenterSW.com. Locations here in Beverly Hills.
Absolutely.
And Huntington Beach, California.
You're not too far from me, like right next door.
Yeah, that's right.
Listen, this is NainaMD, Beverly Hills, Fusion of Science and Beauty. We'll be right back. Welcome back to my show. This is NainaMD Beverly Hills, Fusion of Science and Beauty. And I have a fabulous guest, Dr. John Wallace. He's a dentist, practicing dentist for so many years, but he specializes in a very serious condition that people are afflicted with. That's obstructive sleep apnea. And we have alternatives other than just the CPAP. So welcome back,
Thank
John.
you. Yeah.
We were talking about, had a fabulous discussion about obstructive sleep apnea. We know that the compliance with the CPAP machine is not that great, and these are alternatives, and we kind of got into a lot of discussion, but I really want to focus now on what can you do?
Right.
So they come to the dentist, let's say. What can you do to help this person? Because we left off just before the break on that oxygen is giving oxygen to your body is everything. We know that cancer cells don't like oxygen. We know that mitochondrial dysfunction is a result of it causes low oxygen states. Bacteria, viruses, a lot of them thrive in low oxygen condition.
Indeed.
So simply and this is really unique, a dentist who can actually do something to a patient with obstructive sleep apnea to increase oxygenation.
Yeah, that's
huge.
right. Well, and I'll tell you what's gratifying, and this is how it should have always been.
But it wasn't.
Yes.
It took so many years. I mean, it's been years.
There was an unfortunate, I can't say acrimony exactly, but a sort of a sense of competition between the medical community and the dental community. In that, of course, the medical doctor will treat sleep apnea with CPAP, continuous positive air pressure. And for those that are severe, that is still the gold standard.
But It is a gold standard, but
For
you can
those
do,
who can wear it.
But you could,
Yeah.
but
Yeah.
no, you can even then. You can still come to see you.
Yes.
Even the person with sleep apnea.
Correct.
This is a point I'm trying to make. You guys, synergy. This
Yes.
has been the whole cornerstone of whenever I go and lecture, I go and talk about things. Is synergy. Why are you just excluding everything else and just thinking one pill or just one treatment is the answer? It's synergy.
Well,
so what can you do then?
Yes,
so
what makes our center unique is, and we have the good fortune of collaborating with Dr. Robert Levy. He's a board-certified sleep medicine specialist. And the fact of the matter is, medical doctors and sleep-trained dentists should be working together and are working together. In fact, the American Academy of Sleep Medicine and the American Academy of Dental Sleep Medicine are finally joining hands, having meetings together. And it's wonderful because the fact is that there are three main reasons that the dentist gets involved, the sleep-trained dentist, to make a device to maintain an open airway. Because as we talked about earlier, if I can make a comfortable, streamlined...
What is a device? Tell me what the device looks like.
Yeah, thank you. There are several designs. There are probably a dozen or so that I like.
And what are they? Do you customize, and what are they made out of?
They're highly customized. The FDA-approved devices, oral appliance devices that treat sleep apnea, typically will have an upper element and a lower element. In other words,
does it look like a denture? Does it look like a denture?
It's sort of like like the football player. Right before he calls the play, the quarterback puts in a little guard.
Yes, something to protect.
It's protection. Yeah.
Yes.
So think of a relatively streamlined upper thing that fits over the teeth, like the athlete might wear, and then a lower device as well. Now,
kind of like a removable brace. Kind of like that kind of a thing, right?
Kind of like Invisalign or clear braces, but a little thicker. Then, because we talked about how when one lies down, the oropharynx will collapse. We need to maintain because remember, the upper jaw is not a moving part. The maxilla is stationary. The lower jaw, of course, is manipulatable, if that's a word, and we need to open and advance ever so slightly. There are dentists, unfortunately, that will overdo it and try to move the jaw too far.
Those are the cases I've seen. This overcorrection can lead to a lot of issues, especially this temporomandibular joint.
Luckily, we have equipment, we have software now that allows me to not only measure the volume of the oropharynx, but I can also measure the collapsibility of the oropharynx, and I can optimize. I know exactly the position, both vertically and front to back, that provides optimal airflow through the oropharynx. Fabulous. It's called a pharyngometer, and it's a real breakthrough in dental sleep medicine because only dentists can make and are licensed to make a customized device. My favorite devices are those that are streamlined and sort of fit together like a three-dimensional puzzle, like two pieces of a puzzle, that set and disallow or prevent the mandible from collapsing back. I like the ones that give freedom. Yeah. The patient can say, "Hi, how are you?" and talk to me. There are other devices that are sort of connected with just a number of different designs, but they all are designed to do the same thing. Place that patient in a comfortable position that disallows the collapse of the airway. So, but you're right, when you said earlier, there is a place for certain patients that are severe, that require combination therapy, and that is, they've been given a CPAP by their medical doctor, but they either hate wearing it or they cannot wear it.
Or they pull it out at night.
Yes, or unbeknownst to themselves, they pull it out and it ends up on the floor. I get that all the time, and it's discouraging.
I have relatives that have CPAP, and every time I've gone to visit, it's always...
Or they go on a trip and they don't want to disrupt their travel mates.
So this device, how long do you have to base it? Is it worn at night or can you? Okay.
Yeah, it's worn at night because the whole idea is, no one has a collapsed airway during daytime when you're upright and you're conscious. Your brain is continually
in other words, it's simply it's a shift. It's not something that you have to wear day and night that's going to actually permanently, like braces that permanently move or do anything. This is simply a device that will shift your anatomy, so to speak,
that's exactly
while you're sleeping
to maintain the airway. Maintain the airway.
That makes total sense.
Any dentist, folks, that tells you we got to open the airway is
that's
either
what I wanted to clarify.
Exactly. Yeah, that's what we maintain. And so it's a lot of my patients, they'll tell me this is just too good to be true. And my brother-in-law, for example, he had gained quite a bit of weight and was snoring demonstrably loudly, and we tested him for sleep apnea, and sure enough, he stopped breathing about 20 times an hour. And this
Wow.
is unacceptable. And of course, just tired, and he
Yeah.
quit surfing, which he loved, just didn't have the energy, you know. And just immediately, I fit him. In this case, I just sort of nailed it on the first go, and it was really comfortable. Sometimes we have to adjust it a little bit. These are adjustable to get it just right. But from day one, no snoring, no apnea. It feels like $1 million, and is out surfing, and has lost the weight because now he has the energy to get out and paddle and do his thing.
And you oxygenate. When you oxygenate, you reduce inflammation. You know,
Yes.
And that's one of the biggest things for weight gain is, you know, building up the toxins, building up of inflammation, and so forth.
Yeah, and you know, our patients, they can't necessarily articulate it in those terms, but they'll just say, you know what, I feel like $1 million. I just feel fantastic.
This is
now,
amazing.
It is truly, and it's a real godsend. It is the most gratifying thing that I do.
When did you get it? When did you like start doing
My grandfather, my maternal grandfather, who passed away some 30 years ago, died of complications due to sleep apnea. They didn't know how to treat it back then. He snored like a freight train, which was one of his more endearing qualities. That's what we loved that about him. That was Grandpa, you know. But it was killing him, as it turns out. And he died of a stroke in his sleep. And at the time, it's like, oh, what a peaceful way to go. He was 75. You know, Grandpa might have lived to be 90 for all we know, but he was not getting oxygen for many, many years. So I have a passion for it personally. And as I was saying, it is far and away the most gratifying thing that I do. I'm a general dentist, and I fix teeth, and that's great. But we're saving lives, and well, what can I say? I mean, it's the ultimate calling for us as healthcare professionals. I want to also mention that there are those severe patients who have been given a CPAP machine who cannot wear the CPAP machine because of the air pressure. In other words, it's not that they're claustrophobic. It's not that the noise doesn't bother them. Have you ever stuck your head out the window when you're going about 40 miles an hour?
Yes, I used to do
And
that
it takes
all
your
the time
breath
when I was
away.
little.
Yes, it blows in your eyes. You know, it's fun for a minute, you know,
but then you can't breathe. Yeah,
that's right. You know, I don't do it because it messes my hair up. But anyway, so there are patients that cannot wear CPAP because of the airflow. Well, guess what? There's a place for what we call combination therapy, which is, I mean, they need oxygen, so they wear CPAP, but they also wear a comfortable dental device, a mandibular advancement device, so that we maintain an airway and blow a little bit of air down it. But rather than having the setting, because it goes from about 1 to 20, instead of a setting that might be 17, 18, 19, 20, we can get it down to 4, 5, 6. It's a whisper, it's a little bit of air, and the patient says, well, I can wear this. And so that's another use for the dental device.
That's really great.
In most cases, the dental device is for those who have been diagnosed with mild to moderate obstructive sleep apnea.
And what do you do with children?
Oh, I'm so glad you asked. This is where my wife really excels. And the bottom line is
your wife's, by the way, she's a dentist, amazing dentist. Her name is Dr. Catherine On. She came on my show, I think about a year ago. Fabulous lady. And you should Google up. There's an amazing show we did. So, yeah.
And Kathy did an extensive residency at UCLA. We were classmates at UCLA, graduated in '93 in pediatrics and growth and development. So as we were sort of hinting at earlier, with children, well, of course, there's pediatric obstructive sleep apnea as it relates to child obesity. And a lot of times just by weight loss alone, the symptoms go away. But more often than not, it is a consequence of mouth breathing.
So what do you do to how do you reconstruct?
The reason that children breathe through their mouth and not their nose is varied, but there are 2 or 3 things that keep showing up.
What are the main?
Tonsils and adenoids. Sometimes the ENT has to get involved.
Okay, so you get those out.
Because again, that's an obstruction of the airway. Have you ever seen a child's large?
So what's the second one?
Another would just be narrow nares. You know, just an anatomic misfortune of having or enlarged. Turbinates, for example. Again, the ENT sometimes needs to get involved. Obesity, and then also, as we talked about earlier, just parafunction. There are children that breathe out of their mouth just out of habit. Becomes a habit. And again,
do you do anything different in terms of what do you put a device there?
Thank you. So therefore, it's an orthopedic and orthodontic issue. What Dr. On does and other orthodontists and pediatric dentists like her is we want to fully develop, well, it's really 2 things. We want to develop their little mouth. We want to open up that jaw to give them a normal sort of volumetric or volume of their
So can you do
airway.
an expansion?
Yes, expansion, but remember too.
Is that done with brace? How is that?
Yes, there's an expander. It's called a palatal expander. There's the alpha device, the DNA device, and it basically just expands their little mouth. Now the lower jaw, believe it or not, tends to follow suit. Teeth and jaws know where to go. Just like, with hands and feet. Do you need to guide the growth of fingers and toes and whatnot? No, not really. Although, notice, like in the old days in Japan, ladies would wrap their feet real tight to mitigate and truncate the growth of their feet, because tiny little feet are considered the ultimate in femininity. Okay, well, that's a parafunction. You have gone out of your way to stunt the growth of your feet. And so what I'm getting at is the parafunctions of mouth breathing, tongue thrust, thumb sucking will narrow the arch. These are, I say parafunction.
Remember that, no thumb sucking for your children.
It's abnormal, and it is, let's say, destructive functionality of facial muscles, tongue and thumb. So
this is fascinating.
And therefore, the other thing we need to do not only is to increase the size of their jaw, but to maintain it and to begin to defeat those parafunctions through myofunctional therapy and things like that. We have to teach the children, sometimes with the help of a speech therapist as well. We have to teach them how to breathe and how to swallow and how to function correctly.
Fabulous. Listen, this has been a great show. What are the 3 things that you could just give advice to your? I think for someone, I've already gotten the hint, is like when your child might be, is if you notice that they're breathing through the mouth.
Yes.
Right. Have them go see a doctor. Right.
Yes.
And what are 2 other things that you could, somebody who you find is sleeping at night but then has long gasps, right? Long times of periods where they're just not breathing. You better have them go see a doctor. And what's the 3rd one?
I would say the 3rd one is that snoring is not just an annoying habit. It can, not necessarily, but it may very well be an indicator
and it wouldn't
of
hurt,
a very serious medical condition.
Especially if they're snoring, they're tired, get them to a doctor. You guys need to go see a doctor. So thank you so much. What's the website again?
Our website is www.thecenter, THECENTER, which stands for Sleep and Wellness, thecentersw.com.
Okay, the Center for Sleep and Wellness, thecentersw.com. Please look him up. He's a fabulous dentist right here in Beverly Hills. He's very close to me, almost a couple of doors away. Thanks so much for coming on the show, Dr. John Wallace.
It was my pleasure.
And this is NainaMD, Fusion of Science and Beauty, right here in Beverly Hills. We'll be back next week with another great show.